Thank you, Madam Chairman, and good afternoon to members of the floor. My name is Dr. Faisal. I am from the Islamic University of Malaysia. HIV disease is a profound human tragedy affecting 16,000 people each day, and with about approximately 40 million people living with HIV and AIDS worldwide, of whom 17.6 million are women and 2.7 million are children under 15 years old. The increasing trend has a great impact of rate of infant, child, and maternal morbidity and mortality. In Malaysia, total number of HIV positive until 2010 is more than 19,000 cases, in which more than 30,000 cases were death-related from AIDS diseases. Initially, the percentage of HIV positive was predominant in men, but the number of new cases of HIV positive in women is increasing trend from 9.5% in 2000 to 19.1% in 2008. From 1998 to 2006, there was 1,042 HIV positive mothers identified in government health facilities, and 35 HIV infected babies were born, representing a crude vertical transmission rate of 3.2%. However, in 2013, the crude vertical transmission rate was down to 1.8%, mainly because of adherence to the National Perinatal Prevention Mother-to-Child Transmission Management Protocol, PMTCT. And this is a HIV screening by the Ministry of Health from 1998 to 2013. There is about almost up to 99% coverage for the HIV screening, and the crude for the vertical transmission newborn is 1.8% in 2013. So many of these HIV mothers live in poverty, lack of education about the disease, suffer subordination to men, fear of stigmatization and discrimination, and these lead to the vulnerability and prevent them from their social and civil rights. Although therapeutic intervention plays a vital role in the management of the HIV patients, and emotional, psychological, and personal needs of HIV positive mothers should also be addressed. Okay, I will present two case discussion regarding mother lives with HIV positive. The first case is Madam Haley, 33-year-old, a single mother, was diagnosed HIV positive during the antenatal screening in 2009. She was infected by her boyfriend, who was an alcoholic and substance abuser. However, she denied using any recreational drug. She was started on antiretroviral therapy, ART, at 16 weeks of period of gestation. She claimed to be compliant. She has 2 children from previous marriage, which are well and stay with the ex-husband. Her partner was abusive and intravenous drug user, IVDU. And as due to that, she was placed under Drug Intervention Center, which is a shelter home. And she was referred to Social Welfare and Religious Welfare Department to assist her socially and psychologically. During this period, she was staying away from her family. Baby girl Amy was delivered in the hospital at 36 weeks gestation. Her birth weight is about 2.4 kilograms, and her blood was taken for HIV test, and he was started with an ART prophylaxis until 6 weeks old. Postnatal and eventful, and Amy was confirmed not being infected with HIV after the last blood test was negative. Both mother and child were referred back to her hometown pediatrician and family medicine specialist to continue the ART treatment when Madam Haley decided to go back home. The second case is Madam Ellie, 25 years old, which is intravenous drug user, IVDU. She was diagnosed HIV positive at 24 weeks in her 3rd pregnancy. She's a late booker, but however, the ART and methadone replacement therapy was started immediately. She defaulted treatment at 30 weeks of period of gestation, as she claimed due to the side effect of vomiting. Treatment was reinitiated after a home visit by a health nurse. Baby Annie was delivered at 33 weeks of gestation for reduced fetal movement. Intravenous sirovudine was administered 2 hours prior to the cesarean section, and baby was admitted for 2 weeks. ART prophylaxis was administered for about 6 weeks. However, after delivery, she refused to continue ART and methadone replacement therapy. despite counseling, and went back to drug addiction. She was apprehended and imprisoned for drug trafficking at 6 months postpartum. As she insisted that the baby should stay with her in the prison, both Madam Ellie and the baby then were followed up by the healthcare team that looks into the welfare of the prisoners. So from these two case presentations, the main thing of the psychosocial impact issues that we need to discuss is a woman and their vulnerability. Studies of women attending antenatal clinics find that many women are monogamous and have been infected by their one partner. They are exposed to domestic violence and remain powerless and afraid to request using condom as they fear a violent reaction or abandonment. They also have social problems such as heroin addiction and multiple partners, which make them more vulnerable to HIV infection. And in many cultures, there are social and cultural taboos about discussing sexuality. As a consequence, women have difficulty in seeking information on HIV or obtaining condom. The women also suffer from biological vulnerability, as we know that the risk of becoming infected with HIV during the unprotected vaginal intercourse is as high as 2 to 4 times compared to men. Other psychosocial factor is stigma and discrimination. Stigma is a powerful social level that radically changes the way individuals view themselves and how they are viewed by others. Most people living with HIV and AIDS suffer of fear stigmatization. Discussion of sexual practice or illicit drugs are often taboo, and this is associated with embarrassment, shame, guilt, and rejection, and thus compromised care. They are reluctant to continue the ART or like the second case, or putting their babies at risk due to fear of drawing attention to their HIV status by not breastfeeding. Apart of women and vulnerability, stigma and discriminations, there are other social issues in HIV mother which are equally important, such as their living in the poverty, lack of education and economic opportunities, and violence against women. So the main concern in intervention is not only the medical treatment, but the need for social, peer, and psychological support. And this can help them in coping with their disease, physically, emotionally, and during the crisis. Promoting behavioral changes and reduce the sexual risk behavior and also other high-risk behavior, and enable them to make informed choice about family planning in future, and thus enhancing the quality of life. In Malaysia, psychosocial issues are addressed by the health personnel and the staff from social welfare. Their activities include giving counseling, doing home visit, and place them in a safe social welfare home if indicated. We also have a non-government organizations, NGOs, such as Drug Intervention Center and private shelter homes to assist with the psychosocial support. As a conclusion, from this overview of the psychosocial impact of HIV-positive mother express the needs of more care, psychosocial support and counseling rather than just an information sharing and treatment. And it is also important to assess the risk of domestic and community violence, at-risk sexual behavior and other risk behavior and intravenous drug user, as well as bereavement and death issues. Thank you. This is my reference.